Welcome to another episode of Uninsured by Choice, a podcast where we help you navigate the healthcare system without insurance. I'm your host, Dan. We are brought to you by our sponsor, Zion HealthShare, a nonprofit medical cost sharing community. Today, I'm joined by Dr. Umair Malik, who is a board certified family physician and the founder of Blue Spruce Health, a leader in the direct primary care movement. He spent over a decade in Vermont declaring independence from insurance to provide unhurried relationship-based medicine that puts patients first. So, Dr. Malik, welcome to the show.
Thank you for having me, Dan.
Yeah, absolutely. So, I think everyone would just love to know. I always love to hear these stories. What your background in medicine and practice looks like, and what kind of got you into the DPC movement, and part of that, and just hear your experience there.
Yeah, thank you, Dan. I worked for probably about 7, 8 years in traditional hospital-based primary care. So I was being probably what everyone considers the regular family doctor. The 15-minute to 20-minute visits, full packed schedule, and not much time to call folks back or really do the relational care. So I did that for many, many years before I sort of had this moment, which I think a lot of people had a moment around the pandemic. It was a time for reflection, a lot of downtime too, that let you kind of really reconsider what you're doing. So right around that time, I decided that it was the right moment for a change. Decided to go off on my own and do primary care, but do it the way I'd always envisioned doing it when I was growing up. As a young child, thinking about what family medicine was and what it would be. And the only way I could sort of see that was doing direct primary care, which was basically much more relational, right? It's cutting out any middleman, just working for my patient and having a one-on-one relationship. I've been doing that for about 5 years. Blue Spruce Health has been open for 5 years in Newport, Vermont. We've done fairly well. We've built our own little following, we like to say, and we are looking to the future by expanding and opening a couple new offices, hoping to spread the word about DPC.
That is so cool. I love to hear that people are able to just say, "Hey, I always envisioned things going a little differently." The story you say about being a child growing up thinking about being a doctor reminds me of my oldest. She's not a little child anymore, but when she was little, her favorite show was Doc McStuffins. But when she was playing doctor and putting on the stethoscope and doing all the things, she never went and sat down at a computer and said, time to figure out how I'm going to bill my toys and deal with the insurance nightmare, right? She just took care of toys in this case. But I think a lot of people, doctor is one of those things that a lot of kids say growing up, I want to be a doctor. And I think that's how you envision it. I want to take care of people, not take care of paperwork. And I think the DPC movement that a lot of people maybe don't understand is that you are making it so it's much easier for you as a doctor to take care of people. Can you walk us through the differences between what you were doing before versus as a DPC doctor? How is that different now, and how are you able to better take care of your patients?
Yeah, this might be a bit of a tangent, but it makes me really think about my inspiration for actually becoming a doctor, which, all of my youth growing up, my father, who was an immigrant to the country, came from a different background. And basically his idea of medicine was what you would consider the old school, a doctor coming out to the house and sitting with a family and, looking over somebody while they're in their bed. And there was a point really where my father was really proud for me becoming a doctor. And he'd ask me all the time, he's like, "Oh, are you doing good work? Are you taking care of people?" I was running high on the idea that I'd become a doctor and just accomplished all this. You run on high for a while, that I sort of lost the idea of what it really was. I was working, this 9 to 5 job, which really wasn't 9 to 5. You got to come in early and you got to leave really late because you're doing a lot of the charting and documentation. But it really was that 15 minutes, 20 minutes, you got to hurry. The next person's already waiting in the next room. You've got more charting to do than you do actually have face-to-face time. I was leaving a lot on the table, meaning I'd leave a room saying, I don't think I got to the root of that. I don't think I really got to talk to that person about what's really going on. Why is their blood pressure really high? At 15 minutes, you can't really get to the bottom of it. Every time my father would ask me, with pride in his eyes, it's like, "Are you a good doctor? Are you taking care of people?" There was a moment where I had to say, "I'm not sure I am." I'm not sure I'm fulfilling that vision of what a physician is. And so really I think to get back to the root of it, I had to stop, I had to slow down. And now, we have 60-minute visits, 30 minutes or 60 minutes. And really the patient gets to decide. So they get to book their own appointments. So if they want 60 minutes, we can sit and we can chat. We can have those conversations to say, well, your blood pressure's up because you've been drinking a little more lately. Let's have a talk about that, instead of here's your prescription and see me back in a month to see if it worked. We get to really get to the root of problems now. And that's really what I want to do is I want to get to the solution. I want to get to the root of the problem, not just hand out a slip that just says, here's your pill and come back if it's not better. So it was a pretty large transformation to change from being in a rote system, what I call the factory medicine, right? The treadmill, the conveyor belt's coming. You can't push stop on the conveyor belt. You got to keep going. And sometimes that piece has already moved on and you haven't really quite finished it, and the next one's already coming. I get to think, I get to even pause the conveyor belt and sometimes say, hey, we're not moving on. We're going to take some extra time here to talk about this. And that's really meant that I feel more fulfilled. And the cheat code here is that the patients feel more fulfilled too. So we're all happier in this system.
And that's really the magic of it. When you think about it, there's these articles always coming out about the lack of primary care doctors or that there's a shortage of providers and there's people leaving the industry. And by switching to DPC, both the doctor or the provider is improving their own mental health and their own fulfillment at work, but it's also better for the patients. It's a win-win for people to make that switch. And I've actually talked to several doctors. I was at the DPC Summit in July last year, and there was a lot of people in residency or a lot of current primary care doctors thinking of making the switch. And I think it's interesting that you have now for 5 years got a successful practice up and going in what most people would probably describe Newport, Vermont as more rural, I would say. But now you've also put up a practice in Burlington, which is going to be more bigger city that others might be thinking about. What's been the difference in your experience? What I've heard from a lot of doctors is, well, I'm in kind of more of a rural area. I don't think there's enough people for this to work. This will only work in a big city, but you are kind of pushing back on that. So what's your experience been?
I think that it's been absolutely foundational to who we are that we did start in a rural setting in a small town. This is the kind of town where, everything is built on relationships. There's a lot of trust. Your reputation can go a long way. So there's a lot of word of mouth here. So basically, I would say that our practice opened and we did really well very quickly because of that word of mouth. When people hear that something good is going on, I mean, that spreads like wildfire. So that really did help us take off. I think, the community sort of sharing that they were getting good care, that this was definitely different. It was hard at first because direct primary care is sort of novel in this part of the country. This has been much more popular in the South and on the West Coast or in the Midwest, but in the Northeast, it's been a little slow on the uptake. So a lot of people, we had to educate, what is this system? And this is real, and it's not just some hokey thing, and that this is actually as good, if not better, care than they're getting from other institutions. And actually moving into the more urban setting now in a city that's a little more populated, it's a bit of a different approach to get people to kind of see that. On the one hand, they're much more tech savvy and they get it. They understand that, hey, if I'm looking for healthcare that's convenient, this system makes sense. But it is a little different in that word of mouth spread.
Yeah, that makes total sense. I think it's pretty cool, though, that in either situation, you can thrive. I mean, there are DPC practices from rural to urban and suburban and anything in between where they're doing just fine. So there's not some sort of baked in, you have to, check these boxes for this to work for you. You really could make it work. Like for me, I'm a testicular cancer survivor. And about 2 years out, I had pretty much all the symptoms of low T, basically. And that's somewhat common in my situation. And I went to the doctor for my annual check. He asked the same questions, did the blood test, came back, and I was 10 over whatever the minimum of normal was, like just barely. And in my case, the spread was like 400 to 1200 or some large thing. And if I'm at 410, that's, oh, nope, you're fine. I thought, well, but I don't always really feel fine. I am a member of a DPC practice here and have a doctor here who takes more time to say, well, let's look at these habits or these, lifestyle factors. Maybe you are normal range, but you're on that lower end. Let's see what we can do. Was able to help a lot in that arena. And that's just one example of what I'm sure are many from people all across the country of taking that time really works. Do you have similar kind of experiences without violating HIPAA, of course, of, examples where that's worked out, better for people?
Yeah, I mean, I'll give you my spiel now, which is essentially the thing I think I say the most. But and I love saying this to people when someone comes in, a patient comes in. I love telling them, I worked for you. That means that I'm not paid by insurance. I'm not paid by a corporation. I'm not paid by a government. I'm paid by you, the patient, and therefore I work for you. That means that if you're coming in and saying, look, my testosterone level is considered normal, but I don't like how low it is. Well, then that's now become my priority too. Your priority is my priority. I'm not beholden to some other group. Inevitably, when I was working in the traditional system, I was focusing my own encounter on how can I make this fit within the rubric of what insurance is going to cover? And is this a diagnosis or not? Well, because the number is in the normal, it doesn't really fit in a diagnosis. And so how do I get insurance to come along? But now I don't work for insurance. I work for my patient. So there's, I mean, I can give you a lot of examples where this has kind of become the cornerstone of what's changed things for people. But I think the really take home message that I really want everybody to understand is that who does your provider work for, really? They can say anything, but it's whoever's paying them. So if the patient is paying and it's a direct transaction, then it's a very clear relationship. There's no middleman there.
Yeah, and to that point too, with the way consolidation has happened in healthcare, the provider might not even know who they work for. They are in a
Right.
facility that's owned by a hospital, that's owned by the insurance carrier, who also owns the pharmacy and PBM and blah 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 blah. It's this consolidation where who even works for who's paying who here, and I think that's why. I think the stat is something like 30 cents of every dollar spent on healthcare actually goes to the providing of care. And the rest is this administrative bloat because no one knows who's who's paying who, and there's all these people taking something out. So I love that direct care and direct pay really yield those kind of results. And I'm sure you're seeing those results every day, right?
Yeah, and kind of to your point here, there's the hurdles as well. I give you the example of a 20-something-year-old gentleman who came in not too long ago. He had been playing basketball, he injured his knee, and he came in with what is basically a cookie cutter story to a physician of a meniscal injury, which is a tear of one of those supporting structures in your knee. So he basically gave the textbook example story of how he fell and injured his knee. And of course, he met all the criteria on an exam. So we're checking him out. We say, hey, this is a pretty open shut case. But again, he had insurance. And so we're trying to navigate his insurance. We knew he needed an MRI. The MRI was going to be declined because insurance needed to see an x-ray. They needed 6 weeks of physical therapy. So when we first pushed through the MRI, that was the response we got, is send him to physical therapy, get an x-ray. Well, even the patient knew an X-ray wasn't going to show anything. He was well educated enough to know that, hey, I didn't break anything. I didn't break a bone. And then the physical therapy, he's like, do you think I'm going to do exercise on this? And I was like, absolutely not. I don't want you doing exercise on that. In any case, his insurance had thrown up these hurdles, and ultimately, when we actually did a little bit of math for him. So we were helping him navigate the healthcare system at this point. We said, your deductible is actually about $2,000, which means that even if you get the MRI, you're going to be paying $2,000. At the end of the day, we called up a facility that we knew well and just said, hey, what if we pay cash? He ended up getting the MRI for his knee for about $1,000, which was half of what he would have paid. We didn't have to do any of those hurdles or hoops. We didn't have to clear it through insurance. He paid cash. And even better, he got that MRI within 2 days. He scheduled it at his convenience. He got the MRI done, and he got it done on a Saturday. And by Monday morning, we were already calling the orthopedic surgeon to arrange his procedure. Everything was lined up without any kind of 6 week delay of therapy that he then fails, and then trying to get the MRI scheduled, and then trying to get the orthopedic scheduled. And he had this moment where he was like, I don't think my insurance really helped me in this situation. Everything we did in that case was out of pocket.
A lot of people find themselves in that situation. I love what you brought up, though, is that DPC is gaining a lot of traction. There's thousands of DPC doctors opening their clinics across the country. Like you mentioned, what about an independent imaging center or an independent surgical center? Are you seeing other practices follow suit in that sort of direct care, direct pay, independent of this whole system? Is that getting more popular?
Yeah, I think the imaging centers are a little quicker on the uptake here. We're seeing some places open up where they're offering X-rays that could be, $100 in comparison to several $100 or even $50. So there's a lot of these folks that are beginning to realize that, it's actually way cheaper to just get a simple thing done. But more than that, I'm starting to hear from specialists too. I can tell you the number of I'm approached probably every month by a specialist who becomes familiar with what I'm doing, and they're calling me and saying, "Hey, how can I do this too?" A neurologist or a rheumatologist who's saying, "I'm fed up with this system. I can't really do this any longer," and they're saying, I'll be willing to create a cash rate. I just want to see patients. I just want to help people. We're seeing that shift starting to spread outside of primary care as well. And I think that, probably it won't be very long before we're going to start to see bigger and bigger movements and more places around the country where that's easily done. I think there's already some surgical centers that are doing phenomenal work. They have transparent pricing, and people are willing to travel for that kind of thing.
I saw a documentary. I think it's called "It's Nothing Personal, It's Just Healthcare" or something along those lines. And they interviewed the founder of a surgical center. I want to say it's in Oklahoma, an independent surgical center, pioneering this whole concept of this direct care and direct pay. And it's just so cool to see it just starting. And so I guess the big question is this sort of ecosystem that's being built, is this fixing? Are we seeing a fix to the system?
Well, so this is actually another thing I love to say, which is that, the healthcare system is broken. I think everyone is in agreement with that. It doesn't matter what party you affiliate with or where you grew up in the United States, everyone will agree that the healthcare system is broken. And my personal take on it is that that's not a system that we can fix. And it's broken, and we actually may need to let it break and die completely. I'm seeing a lot of this. The cash pay system is circumventing. We're bypassing that system, and bypassing that system, building something new. And ultimately, the broken system doesn't have to die, but at least people are seeing that there's choice. And with the choice, they're getting to choose. They say, well, I can go this route or I can go that route. At the end of the day, that's what I think a free market should be, what a free market is. And that's what healthcare was always based on, is choice.
Yeah, it's they say, "Oh, there's always been choice." No, there's not. You just pick from one bad insurance option or the other. That's not really choice.
There's healthcare systems that love to say, we take this and this and this and this insurance. At the end of the day, a direct primary care is the only system that can take anybody, because a healthcare system that only takes certain insurances can't take uninsured. But we take uninsured, we take undocumented, we take anybody at any time for a very fair cash rate, transparent from the outset.
Yeah, and that's the big thing too. I know there was a law that was passed. I can't remember when, and the name was something along the lines of healthcare price transparency. And the idea was everyone needs to provide transparency in pricing. A good idea, right? That should work. But all of them tried to circumvent that with, "Hey, we'll just post the pricing in some sort of file type that no one can open on a normal computer, or we'll make these files, 20 gigabytes and take forever to download, so no one can see them." So they're technically compliant with the law, but not really. And you just see this over and over again in the traditional system of how can we keep things as opaque and expensive as possible. And so doing something to, like you said, circumvent that system and just build essentially a separate system, right?
I'll take it one step further, Dan. It's been always a pain point for me that, when I was working in traditional primary care and I referred somebody out to a specialist and they came back to me, and I'd say, well, what happened? They said, well, he walked in 5 minutes. I was there. I drove 2 hours to go see the specialist. It was a 5-minute visit, and they never really addressed the issue I was there for. And boy, I'm pretty upset. And while the patient may not understand the whole context of it, as the referring physician, I understood it, and I said, this really wasn't good care. But there's no recourse there. There's nothing that they can really do other than maybe file a complaint. Tying back to price transparency, to me, direct primary care goes way above that. In our practice, at least, our prices are transparent, but whenever somebody is really kind of making the case that they're unhappy or something wasn't to their standard, or there's a misunderstanding about what care they were receiving, we can issue a refund. That doesn't exist in healthcare. It almost never happens here because most people are inevitably happy with the care they receive. But there have been times where we say, this situation wasn't really the way it didn't turn out the way we wanted it to turn out. And you paid this amount, and we're gonna honor the transaction. We're going to refund you what we think that was worth. That's going, just to me, beyond price transparency. It's accountability too. I don't know anywhere in healthcare that you can do that.
Yeah, in fact, it can be the opposite because my experience, again, as a cancer survivor, I was on surveillance, an annual CT scan. Just 2 weeks ago was that anniversary. So there's two places in town that'll do that. One's the hospital for $3,500. Then there's this other smaller facility that does it for about $1,500. So I went in there. This time I was very clear. I am cash pay.
Mm-hmm.
They had no idea what to do when I was checking in. Go sit down. Wait a minute. And so it took them about 10 minutes till they called me back up and said, okay, we need you to sign this. If you pay today, right now in full, it's 1,000 something. If you want us to bill you at the cash period, it's 1,500 something. I said, great, I'll pay right now. And I did, and went and did it, and everything was great. Well, yesterday, guess what comes in the mail? A bill for $1,500 that says I've got $1,000 credit, but I still owe 500 more. And now I have to go dispute the bill because they just don't know how to navigate this idea of someone showing up without insurance. And so you just need to find these facilities and these providers that understand how to work directly with you. These legacy facilities, they just are confused by it. Like you said, you can't work within the system to fix it. You just need to let it die.
It's the most basic thing, right? That you're paying for a service. If I'm selling something, I should make it very easy for you to be able to pay me and never, never create any hurdles between you and me in that regard.
Yeah, basic marketing, right? You don't want obstacles between your potential customer, and paying for the transaction. But that just seems to be what happens left and right because no one understands the transactional nature of this traditional system. Because who gets it? Oh, you pay it. No, you pay it. No, you get this and you get that, and it's just a mess. And it's so refreshing to see this direct primary care movement really ramping up. How have you seen it change just in the time? I mean, about 5 years, I think you said you've been in this space. What's it looking like today compared to then?
Yeah, just in the 5 years alone, 5 years ago, I really had to do quite a bit of education to say this is what this is and this is why we bill. I had to spend a lot of time explaining to people why I don't bill insurance for my care. It was one of those things that was just, it really came across weird, right? Today, very few people are really raising an eyebrow at that. They're understanding. They understand. They're saying, oh yeah, we get it. Insurance is a nightmare for everyone, including the patient who's trying to use it. Already that space has changed so much in that there's so much more acceptance and understanding. People are jumping ship. They're jumping off of insurance. So this year alone, with the increase in premiums, I've had so many people call up our office saying, I was on insurance. I'm letting go of that now because it's just untenable. It's too expensive. They're choosing to be uninsured. Previously, 5 years ago, it was usually the person who said, "Look, I just can't make insurance work, and I'm struggling, so I don't make I make too much for Medicaid, but I don't have a job that can get me insurance." Today, I'm getting calls from people that are saying, I did the math. I sat down and I made a conscientious decision to abandon my insurance. So it's a very different type of person. So in the 5 years, this has become much more popular. It's become much more of a choice. People are starting to have an awareness. They're being more savvy about understanding that, hey, I know that I could get this surgery. I may have to travel a little bit, but it's 1/3 the price, and it's just as good quality, if not better sometimes, because the follow-ups are really extended, and you get a lot more doctor to patient FaceTime. You can't get that anywhere else. I'm really optimistic. I mean, again, I think that awareness, that knowledge that's spreading. There's more and more providers opting in too. There's more and more facilities that when they hear about what we do, they get it and they're saying, okay, we were going to carve out a cash pay rate for your patients. So before it was just not anything they were willing to talk about.
A lot of progress in just those 5 years. What do you think the next 5 years hold? What do you think the healthcare system looks like 5 years from now? Is it kind of the same or change?
Yeah. Well, we just came back from a conference that kind of highlighted a lot of the upcoming trends, the tech, the software that's in healthcare. I think insurance thrived off the obscurity of things. And you mentioned opaque earlier. Everything was just so nebulous and hard to navigate. But we're living in a world where software and tech is making things so streamlined and easy. It's pulling the veil up and it's basically exposing everything. What we're seeing is that things are so much more streamlined and efficient that I would have said it's going to take 10 years for things to shift and for traditional insurance to break down and fizzle out or die completely. But I think it's actually shorter than that. I think the time frame is probably within 5 years that we're going to see a major shift, and either there's major reform on the insurance side to make it more tenable, or it dissipates completely. It's really amazing what's coming up now and what's making direct relationships so much simpler and easier. I mean, telehealth is an example, right? It just makes sense that you can get care over a phone now. But traditional insurance doesn't generally support that. And more people get that. The mom who calls me up and says, I've got 3 kids and they're sick. Do I really need to bundle them all up? I need to get in the car. My husband's at work. I got to figure out all of this to get them over to the office to get checked out. She can show me some pictures. I could see a rash. I could see a stuffy nose. I can hear about how the breathing is going. And I know that family. I can take care of them 5 minutes over the phone. Digital communication, a text photo, or even moms who will record the breathing or the cough. And I hear that cough and I say, boy, he's really wheezing. That's pretty clear to me. His asthma's flared up. I know this kiddo. You don't have to drag him in. I'll take care of it. And that mom who just says, thank God, 2 are screaming, one's got to get buckled in. She couldn't even put a value on what that is, what that relief means to her.
Yeah, and if you look at tech just in the last 5 years, boy, how far have we come 5 years ago to today? And like telehealth is a good example. I remember scrolling through my LinkedIn and I saw someone post and say, oh, there's big news. Billing companies and insurance carriers are going to start using AI to aggressively up the bill and figure out how they can charge you more. And right below it was, I don't remember who it was. It was DPC Doctor or some healthcare advocate saying, you can start putting your bills in AI and bring them down. And I thought, well, now the AI tech wars are going to start where one's trying to up bill and one's trying to bring it down, and AI is going to fight itself. It goes back to the opacity of insurance. It's, what are all these codes? What do they mean? That's breaking down. And that's where insurance has thrived, is on that lack of transparency. And with it becoming more transparent, I don't know how much longer insurance can thrive in that.
They had a great line at the Hint Summit at the conference I just went to, which was care over codes. For that mom that had those 3 kids, they weren't a code. There was care. It was a situation for a family, and it had nothing to do with codes. That whole encounter was done over the phone. Yeah, it's tough when you have to reduce that down to a billing widget and trying to make that fit into the system.
Yeah, absolutely. Well, appreciate your time today, Dr. Malik. This has been an awesome conversation. Anyone listening, though, if they wanted to reach out, connect in any way, what's the best way for someone to find you online?
Yeah, check us out. Our website is bluespruce.care. Blue like the color, spruce like the tree, and .care because that's what we do.
That's perfect. Love it. Thanks for your time. Appreciate you joining us. Anyone listening, keep in mind you can always subscribe on YouTube, Apple, or Spotify, and we'll see you next time.